Good day, ladies and gentlemen. Today I would like to delve into a critical topic at the intersection of technology and healthcare: augmentation flow of work within healthcare using AI. As we stand on the edge of a new era in healthcare, one marked by unprecedented challenges and opportunities, it has become increasingly evident that the integration of artificial intelligence can revolutionize how we deliver and manage healthcare services. With its ability to process vast amounts of data, recognize patterns, and make data-driven predictions, AI is poised to enhance every facet of healthcare. From streamlining administrative tasks to assisting clinicians in making more accurate diagnoses, AI is poised to augment and optimize the flow of work within healthcare in ways we could only dream a few years ago. One of the key challenges in modern healthcare is the increasing demand for services, which leads to workforce shortages and burnout. This is where AI can step in as a valuable ally by automating routine administrative tasks like appointment scheduling and billing. AI allows healthcare professionals to focus more on their time and expertise on patient care. This, in turn, leads to improved efficiencies and ultimately better patient outcomes. Moreover, AI's ability to analyze complex medical data, including imaging and patient records, can provide clinicians with invaluable insight. It can help early warning signs, predict disease diagnosis, and suggest personalized treatment plans. This enhances the quality of care and empowers healthcare providers to make more informed decisions. However, it is essential to tread carefully in this brave new world of AI in healthcare. Privacy concerns, data security, and other considerations are paramount. As we leverage AI to augment our workflow, we must ensure patient data remains protected and that AI algorithms are transparent, unbiased, and accountable. In conclusion, integrating AI into healthcare represents a transformative leap forward. It has the potential to augment the flow of work within healthcare, alleviate the burden on healthcare professionals, and ultimately improve patient care. But as we embark on this journey, we must do with a keen awareness of the responsibilities and challenges. I thank you for attending today, your attention. So now let us explore this exciting and evolution landscape of AI and healthcare together. Here with us today, we have 4 leaders from post-secondary education, academic AI research, and AI robotics to discuss this exciting and emerging trend within healthcare. To preserve our time today, I would direct you to your program for the bios provided on our panelists for information about their credentials, details, and interest and esteemed careers. If you are interested in their work, please get in touch with them individually following this presentation. First, I'd like to introduce Mr. Dwayne Buckles. He is the Business Development Manager with Pringle Robotics. Our next panelist is Dr. Cody Bumgardner, Division Chief for Pathology Information at the University of Kentucky. Continuing, our next panelist is Dr. Jeffrey Talbert, Professor and Division Chief of Biomedical Informatics at the University of Kentucky's College of Medicine. And finally, Dr. Roderick W. Jones, Senior Statistician with the Kentucky Community and Technical Community College System. Gentlemen, welcome, and we've been looking forward to this discussion for a time. So, I want to start with Dr. Bumgardner and ask you this question. How do you foresee AI technology reshaping job skill requirements, and what strategies should healthcare institutions employ to prepare their workers for these evolving roles?
Well, I asked ChatGPT, but it didn't provide any proper answers. This is something that's happened after 2021. So in 2017, I started the Division of Pathology Informatics at the University of Kentucky, and what comes along with that is resident training. And had a young woman tell me as I started a lecture, she stopped me and said, "I don't know why I'm here. I will never use any of this." So that wasn't good as a young professor to certainly hear. And now 7 years later that Informatics is part of the pathology boards, I have young people come to me and say, "I'm really worried that I can't pass my boards because I don't understand the material." I also have people come to me and say, "Will I have a job in radiology or pathology in 10 years? Which I answer, yes, these need to be enabled tools. But part of this is the landscape is changing. In the last 2 days, this includes, last 3 days, I've had 6 conversations with 6 different groups on generative AI. This isn't normally us peddling technology and trying to push it into the clinical space to try to do something interesting. These are people coming to us and saying, "I think these tools will be useful. I don't know when it's appropriate to use it. I don't know how it's appropriate to validate, and I don't really know what to do with it other than I'm pretty sure it will help me." So I think education and training, getting out of the way of people trying to use these tools that they think can make their job easier and safer are probably the best things that we can do.
Thank you, Cody. So the next question I have is for Dr. Talbert. Jeff, how can LLMs reduce administrative burdens and augment what clinicians do regarding diagnosis?
Thanks for that. And again, LLMs are large language models, so those are the ChatGPTs, Claudes, et cetera, that are out there. I think before we kind of answer this question, I want to start with the way to kind of group these tools into a couple of different buckets. And so one is things that are administrative burden reduction kind of tools, if you will, for things that clinicians are already doing, as opposed to other things that may be things that clinicians don't do right now that the tools are working on that they'll be able to do in the future. And so those things that we're not currently doing, those are usually things that have to go through the FDA, and there's a process for that. And so the FDA, before ChatGPT, already had about 500 of these algorithms approved for use in clinical settings. That's going to explode now with how different things are with the LLMs as we go forward. But let me just tell you about a couple of the tools that are kind of currently available, if you will, within EHR systems, or the leading EHR vendors are putting these in their systems as fast as they can. And these are things that help clinicians do things easier and simpler, not replace clinicians in any way. But the first one is that if you think about, if you ask one of my division chief colleagues in the College of Medicine what they hate the most about their job, and it has to do with documentation. And so these tools can do documentation kind of automatically. They can listen to a conversation, develop a script of that conversation, and then give it back to the provider at the end of the day, and they have to just edit it and fix what's right and make sure it wrote down the correct things. So automated documentation is something that I think is on the near future very quickly. Other things that clinician offices don't like to do are things like prior authorizations. So LLMs can be trained with insurance company regulations, and those regulations can then be automatically implemented. And again, they're not going to do it by themselves, but it's going to suggest to the staff person or to the clinician, this person is approved for these things, kind of pre-done. So again, just kind of simplifying their job. Expedited coding and billing. So again, we have lots of coders now that we send these text of visits off and they code and come back. A lot of that's going to be done, at least initially, through some of these tools going forward. Prescription refills. So when I call in to do my prescription refills now, somebody physically has to pick it up, look at it, and either approve it or send me something back saying, no, you need to have this, or you need to go get a blood work done, or whatever it is. All that can be automated by these tools according to the regs that are currently in place. And the last one is kind of screening patient information. So a lot of us, before we go see our provider, will fill out a big, long form, and then somebody has to either type that in, look at it, and then decide what they're going to do with it. Well, these tools are great at summarizing information like this. So that information can be put into this system. The system will come back and then flag 2 or 3 things that the provider should do in that particular encounter. So those are my starting points.
So Jeff, I have a follow-up on that. A lot of us don't understand how you train that model.
That's a great question. A lot of the models, that large language models, you can download them, the models that have been trained on their millions and millions and sometimes billions, I guess, of documents. But then when you get them locally, what you do is then you retrain them on your local information, and it's a much simpler process than the initial creation. So, for example, lots of universities, including UK, we're working on this now too, we're going to deploy our own LLM model locally. That gets around a lot of the privacy concerns. When you type something and put it into ChatGPT or Claude, it goes somewhere you don't know where it is, right? And it sends you something back. But you're reluctant to type patient information in that because it's maybe not be HIPAA. You don't know what's going to happen to it. But if it's a local model, then you know that it's secure, and then you know kind of what it's getting back to you. So that's kind of the process that most places are doing these days is adopting a large language model tool, setting it up locally to run locally with their own data.
Excellent, thank you. So now I'd like to move to Dr. Jones. Rick, how do you foresee AI technology reshaping job skill requirements, and what strategies should healthcare institutions employ to prepare workers for these evolving roles?
Yeah, that's quite a question. So we recently conducted a study looking at risk of automation at the occupation level, and we're looking at how our programs align to occupations and asking the question, how likely is it that our programs are going to be feeding into occupations that are going to automate in the future? And when we look at that, what we see is the lower level of education that's required for the occupation, the more likely it is the occupation will be to automate. So what that means from a post-secondary standpoint is that if we're trying to recruit more students, we need to provide the messaging that you're going to need more education, not less, as you move into the modern workforce that's automating. So as we look across all these different occupations, there's some that are going to be completely automated out of existence. A lot of them are in healthcare. Some of them are in other industries that you're probably more likely to think of, things like manufacturing. But there's going to be other occupations that are kind of augmented. So the occupation itself isn't gone. It's just you have to change how you do the work. So I think of airline pilots. So back in the day, airline pilots did not have autopilot. They would fly by their skills and instincts. Now, commercial pilots use autopilot to help them get from point A to point B. And so I think we're going to see a lot more of that in different occupations. Truck driving is another one that I think of. People are very scared about what's going to happen with driverless vehicles. Well, truck drivers do a lot more than just drive trucks. They check their loads, and they have to make sure that they're complying with different kinds of laws and regulations. So there's all kinds of things like that that we shouldn't necessarily be scared of as it relates to AI, but we should be embracing. And so when it comes to education, trying to shy away from discouraging the use of AI by students because we're afraid of dishonesty or things like that. Instead, we should be thinking about how we can get students to think about using the technology, how it's going to change their lives in the future, and how it's going to change their professional experiences once they get out of college.
Thank you. So Dwayne, you're in the robotic industry. Pringle Robotics is there with current AI applications. Question for you is, what are some of the current examples of robots plus AI in healthcare settings that are growing and past early adoption?
Thank you, Carl, for that question, and good morning, everyone. As the only non-PhD up here on our panel, you'll hear a lot more practical and pragmatic solutions. So there's really a couple of answers to that within a hospital setting. Primarily in EVS and cleaning and disinfection type applications, and then also in the delivery. So first, looking at EVS, we're looking at cleaning floors, disinfecting rooms, whether it be operating rooms or patient rooms, using robots, using autonomous driven robots actually. And secondly, on the delivery side, we're looking at things where maybe you want to deliver from the first floor, where the pharmacies typically, up to the fourth floor in a very secured environment. So we can actually have a robot that actually delivers from the first floor, integrate with the elevators, and then go up to the third, fourth floor, whatever the patient's room may be, and deliver those pharmaceuticals. There's also other things. So I've heard that there was an example where the typical nurse walks 30,000 steps per shift. Well, what happens if you have a delivery robot that can actually help reduce some of those steps? Obviously improving the satisfaction of the nurse, but also allowing that nurse to spend more time with the patient himself, and allowing the robot to go back and forth to the supply closet to get whatever supplies it needs, and or else going down and maybe going to the cafeteria to get food or drink or whatever that the patient may need. And we'll talk about the future of that in a moment, but there are some things on the horizon. Currently, most of the robot applications using machine language as a subset of artificial intelligence. So hooking the internet up with that, with all the the cloud applications with AI, that's going to really explode the robot market. So thank you.
Thank you, Dwayne. So, Cody, back to you. As AI-assisted tools become more prevalent, how can we ensure healthcare professionals are equipped with the necessary training and competencies to effectively collaborate with AI systems while maintaining a human-centric approach to care?
Yeah, so I want everybody to imagine 12 kittens on your table that you're responsible with keeping them on there personally. So neuroscience tells us we can only do conditional probability on 5 to 7 things. That seems to be an animal limit, that we can't make decisions on variables more than that. We can distill those things, but we're not talking about AI to necessarily solve today's problems. You're talking about tomorrow's problems with vast more quantities of data. There may be 1.5 million variants between you and me in our genome. There's massive amounts of images that people can't even look at because there's a greater ability to generate the images than not. There's 7,000 laboratory tests on blood alone. So I think people are doing the best they can, but there's a lot of data out there that doesn't end up getting distilled into something where people can make actionable decisions. And tool is the operative word here. When we're talking about a tool, we're not talking about a replacement. There are certainly AI and FDA-approved cases where we're doing a certain diagnosis. The FDA guidance, though, for the United States, is a little bit different in the EU, is having a human in the middle. So at all points of training, validation, and continuous evaluation of these things, you want a person to be that. It's also biased towards the environment that it's supposed to be used in. So I think a lot of this is learning that there are lots of new sources of data, figuring out good ways to have it distilled, being able to use AI tools as a enhancement instead of something that is a replacement. There are positions, I think you talked about, what would be considered low-skilled. Well, there's also high-skilled people that do repetitive things. So they make, in pathology, we have one group of people that would rather do simple cases and do 100 of them, and one person that would rather have 10 cases that takes them 2 weeks to do. There are cases like we have in automated testing in other laboratory tests where before people were pipetting things all day long. Well, that became automated lines because we, as a group, have decided that we trust machines and we can validate these things to do certain tasks for us. So I think you'll see a transition for people that can adopt certain tools to then transition their effort into more interesting areas. And you'll see certainly the summarizations like Jeff had talked about to take large amounts of data and distill it into things that people can make decisions on.
Thank you. So Jeff, let's go back to that LLM area. So how can LLMs reduce administrative burdens and augment what clinicians do in the treatment and prevention areas?
Sure. I think in this area, what we're looking at is things that are kind of evolutionary advances over what we've done in the past. So in most EHR systems, there are some things that identify high-risk patients, and those are usually done with kind of standardized algorithms, mostly driven by age. But we can get much more precision or personalized these days. And so the algorithms can be much more advanced and have hundreds of parameters in them. And so we're basically getting more accurate identification of high-risk patients through some of these models. Same thing for screening. If we think about screenings, everyone over 50 should get a colonoscopy. Well, there's a lot of different conditions that may be sooner or that people may need those screenings. So plugging that information that's already in the electronic medical record can identify those personalized habits or personalized prevention things that can be recommendations to the clinician. There's a couple of the EHR vendors, one in particular, I'm not going to mention names, but they have a tool that actually can suggest a diagnosis. So you have a patient in front of you, you can hit this little button and it'll look through all the patients that use this EHR all across the country and say, of all the people that I've seen, this is what their diagnoses have been. And then that clinician can look at those and say, okay, I have 2 to choose from, maybe there's only one, and it's what I thought anyway, but this is nice to have this kind of feedback from that. They can also click another little button where it shows them then what were the treatments done to these people across the country. And so immediately you kind of have this research study that would have taken my research team several weeks to pull together on folks. They don't have to do it anymore. It's just instantaneously right in front of them within the EHR system. So having those tools is a really great example of that. The last one is an alert. So if anybody that's worked with EHRs know that you get kind of alert fatigue because it goes off and tells you all kind of things you already know. So hopefully the LLMs and the other AI tools are getting much more smarter alerts where they won't go off when you don't need them, and they'll only give you information that you actually need.
Thank you. Interesting. Rick, let's go back to KCTCS. What are the biggest challenges facing KCTCS in the context of artificial intelligence?
Yeah, so this is another one where there's a million areas potentially to talk about, but I'd probably like to focus on 3 areas. The first one is professional development of faculty and staff. So ensuring that our faculty and staff are at least on par with our students in terms of their understanding of this technology is essential. So for faculty, that might mean learning how to use AI to plan lessons and to get creative with using AI, to ask AI, how would you create a lesson plan around using you, and come up with all kinds of interesting ideas around that. The second area is related to student success. So trying to make sure that students have access to this technology. One of the things that COVID really made clear in higher ed is that not all of our students have equal access to things like the internet, for example. And so making sure that our students have access to this technology in terms of the internet and can get the technology in front of them so that they can learn it. And then the third area for us is how can we use AI administratively? So from a strategic kind of planning standpoint. So I'm a statistician. I do a lot of work for our system, looking at kind of big questions. And so one of the things I might be interested in using AI for is doing forecasting of different things. So what's our tuition forecast going to be? What's our enrollment forecast going to be? Our graduation rates and so on. And so we're already applying some of these technologies in some programs that we are actively maintaining and running, data programs where we're producing, healthcare forecasts for every county in the state, and how many nurses are we going to produce, and forecasting that out to 2030. And so all of that is being done with AI. And so we have a lot of opportunities at different levels of the higher ed system to apply AI to try to make us more efficient and to honestly to make the situation for future students better, because we need to be able to train them to use this technology.
Thank you, Rick. Excuse me. So Dwayne, back to robotics. Give us an example of a service bot that is currently using AI and the potential applications to augment the healthcare workforce.
Thank you, Carl. First, I'd like to revisit the first question about how robots are used currently. So I'm going to go back to an EVS example, cleaning robots that would mop the floor, scrub the floor, clean the carpet, disinfect rooms, and so forth. So for example, at Mayo Clinic, we've got about 10 robots there currently on their way to 20, 30, 40, 50. So it'd be a fleet of robots. So you think about your EVS cleaning crew that comes in maybe third shift or second shift. Usually maybe let's say it's 10 people or so that do the cleaning. 2 or 3 don't show up. That's typically they either taken another job, got burned out, didn't show up, whatever. So that's left the rest of the crew to do all the cleaning. And nobody likes mopping floors, nobody likes sweeping. So what do? They usually empty the trash cans, they may wipe down the surfaces, make sure everything's clean, but they leave that mopping and cleaning to the end. So that's where the robots can come in. And here at the Workforce Collaboration, we talk about fleet managers of robots. So as an example, that would be a higher paying job. So you'd have somebody on your staff that actually manages that fleet of robots. So if you can imagine that person, that's in charge of all the mapping, all of the back scene type applications that go onto a robot, that is a higher position that's going to command a higher dollar amount. And then when you put that on your resume and another hospital or a medical organization looks and say, hey, I need this service too, that's going to create an entire new field. So again, that's just kind of an example of an existing one. But as far as what we're currently using, artificial intelligence is typically like a concierge type robot. So you walk into a hospital and say, I have an appointment with Dr. Smith. Can you lead me there? And that robot will say, yes, I can. It'll actually lead you to whatever their office is, whether it's on the first floor or maybe to the elevator, take them up to the second, third floor, whatever. And during that interaction, there's a Q&A. So right now we just pre-program them with standard Q&A because honestly we're kind of afraid to turn it loose with AI, and you never know what kind of answers we get. So we want to have a pre-programmed question and answers with the patient as they're walking to their doctor's office or so forth. And they can go through any type of hospital rules and things that they need, particularly like during COVID where they had to wear a mask. But now it's just they can ask, what's the weather tomorrow? I mean, they can always carry on that conversation. So it's that kind of a general, more relaxed feel as they're being led or are guided to the doctor's office they're looking for. So that's one example. Some other examples that we're looking at is first responders. Let's say you're on a patient floor and you've got potential for patients that fall. So typically you might put sensors into the beds, or you have an accelerometer onto your smartwatch that detects if they're indicating for falls. And we'll talk about some future applications of that, but that robot could be that first responder, the same type of concierge type robot that is smart, that interacts, that talks in human voice like an Alexa or something, and be that first robot on the scene instead of the nurse, which may be busy with another patient. So we understand within the hospital setting that seconds count for for accidents and so forth. So that's one of the other applications we can use artificial intelligence for currently, and we'll talk about the future maybe next. Thank you.
Thank you, Dwayne. So Cody, back to you. With AI-driven advancement in predictive analytics and personalized treatment plans, how can healthcare organizations and educational institutes collaborate to ensure responsible implementation of AI?
Yeah, I think the first thing we have to start doing is thinking about data and raw data as a tool, as something that's very valuable. So I have a slide that I usually have that shows a person. It's a kind of a physics drawing of throwing a rock off the side of the hill and explaining the potential energy versus kinetic energy when the rock hits the ground. Well, the raw data we have is potential information, potentially actionable information. It could go lots of paths. But we have clinical pipelines that the data goes down. But what the hospital systems value and providers value is the actionable data at the end, the diagnosis, the code, the measurement. To employ AI, you also need the raw data. So as hospital systems, we're typically not going through the process and paying to curate that raw data in a way that would make it useful to match up against the results. Not just to develop our own AI, but to actually validate even FDA-approved products. So that's something that everybody needs to think about is, am I throwing away valuable data that could be used in this way? The thing about bias, and you usually hear AI and bias in a very negative light, but bias can be a good thing, but it needs to be measured. So part of the education of how do we use AI, how do we evaluate it, part of that is knowing your data, knowing the provenance, knowing is there certain bias towards populations or diseases and those sort of things, but being able to measure that when you go through the validation process or the training process. We have some, if you look at the funding in this area, it's really exploded over the last several years to make sure that the things that we're developing, we actually know what group it works for and how well it works in certain areas. So when we talk about bias, you want it biased towards the population, you want it biased towards the processes in the hospital, and maybe different staining methods that one group has or different ways that you measure things. So there's a bit of it with slight changes in clinical workflows and maintaining the provenance of data kind of along the line allow us to do very interesting things at the end of the day, because in some cases you may need 10 years worth of data to do something with it versus just buying a device, because those devices have to be accepted and validated, and most institutions are not prepared to do that. So I think we'll have institutions, top-tier institutions, that will deploy AI for the sake of deploying AI and being on the cutting edge. You always see that. What you might not think about is that areas where, let's say, necessity is the mother of invention, where you don't have enough people and you don't have people that can go out in remote areas and do things, like a remote village in Nigeria, where we write grants to get devices to send out there because they'll employ it. They don't have any choice. They have a centralized system in a city, but if you want to change healthcare in those areas, they're pushing technology out to the edge. And unfortunately, we end up in the middle sometimes where we're large enough to have compensation to be able to do things maybe not so well, but we're not basically in need enough to deploy AI. So I think at the end of the day, bias needs to be measured, and in some cases enhanced towards one group or the other. It needs to be reported. We forget about one of the P's in HIPAA about portability and having access to data. having good encoded data that we can know whether things work or not. And that's the sort of things that we could show. One technology may work better than another technology in a certain environment.
Thank you, Cody. Excuse me. Dr. Jones, I'm going to direct this one to you. How can AI technologies be used to improve KCTCS and the outcomes of its students?
Yeah, so drawing on what Cody just said and what Jeff said earlier, so I really think that the future of AI, at least the immediate future, are in two things. So the first thing is in advising. So I really feel like we're going to see ChatGPT-like customized programs that are tailored to specific institutions, where students can go and ask the AI, how do I apply for financial aid? And what is the next step in my process of getting enrolled? Things like that. It's stuff that we think of a lot of times falls to advisors. Sometimes those students haven't made it into our institutions yet to where they can be advised. So they're doing this work, before they're even in our institutions. But for advising, I used to be a professor. I would advise 50, 60 students a semester, and it was a lot of my time was spent advising. And I miss a lot of that work because it was very meaningful, and there was a lot of personal connections built between myself and my students. But there were a lot of questions that I would get as a professor that I would kind of think of, that's a little bit of waste of my time. I could be focusing on my lesson planning or my research, not answering a question that my student honestly should probably know the answer to. And so there's a real space there for AI to fill an advising role. Now, most institutions have trouble with advising capacity. So there's just always a need for it. And so if we could make our actual advisors, this is kind of another example of augmentation where we're not going to get rid of advisors. Like that's not going to happen. But what we might do is allow advisors to focus on that interpersonal connection kind of work as opposed to answering kind of little silly questions that our students should probably know. The second area that I think we're probably going to see that's kind of similar is in tutoring. So, there's a classic study that looks at the effects of tutoring on student performance. And what we see is if you're a student and you have individualized tutoring, the likelihood that you're going to do better is quite a bit higher. 2 standard deviations higher is the classic finding. And so the problem we have is that we don't have enough tutors to provide individualized tutoring to every single student. We just do not have that capacity, and we probably never will, except if we apply AI to that role. So using AI as a tutor, and there are ways that you could train an AI to respond that would be a bit different than a ChatGPT response. I kind of think of a ChatGPT response as an immediate answer to a question. A tutor version of ChatGPT would answer a question with a question. So why did you ask me that question? How did you arrive at the logic that you're using to apply to the question that you're trying to answer for your class or whatever it is, and work it backwards so that the response from the LLM is a learning-based response, not just answer a question type of a response. And so I think we'll see those two things coming online very soon.
Thank you, Rick. Dwayne, pull out that crystal ball at Pringle and give us a glimpse of what's in store for the future of AI plus robotics.
Thank you, Carl. That's obviously a very loaded question for the future because it's hard to predict the future, especially with AI helping along. But the way I kind of envision it is a lot of us have probably experienced telehealth, telemedicine in the last couple of years during COVID. So if you imagine a robot, let's call him Dr. Timmy, who can go to the patient's bedside, and on board that robot is all the diagnostic equipment that you need, a stethoscope, electronic stethoscope, where the patient or just an assistant can actually place it on different parts of the heart or listen to the lungs, oxygen sensors, obviously blood pressure monitoring and so forth, but checking all your vitals and obviously doing that remotely by the doctor who may be 100 miles away, maybe 1,000 miles away. But imagine that even taking it even a step future. Let's say you're taking a CT scan, and maybe that robot can actually do the CT scan in the room. Again, it sounds impossible now, but a few years ago, we didn't imagine 5,000 songs in our pocket and a camera and a phone that fits in our pocket. So that could happen. So imagine you're taking a 3D scan of the patient, taking all the vitals and so forth, and obviously AI is keeping track of all this. looking at things, going out to all the different journals of medicine worldwide in different languages and interpreting this. And again, with this 3D model of your body, sort of what I would call a digital twin that exists in cyberspace, but be able to take predictions. And you got 3D model, well, take that fourth dimension, which is time, and project that into the future. And AI, I think, can assist in some of that diagnosis. I know, we've talked a little bit about that up here, but having that on board the robot. Now, taking it even more steps, which there's some trials with NIH up in Boston with, the same robot can actually do some facial recognition. Now, it's not going to take a picture of your face, it's just looking at tags and expressions of your face. So there's over 50 different tags that it's looking at, and it can tell if a patient is happy, sad, aggravated, maybe just need to go to the bathroom. So it can predict all that, or look at a person and determine that. And perhaps that's something that we can actually use, to diagnose mental health. And maybe by doing this and identifying early signs, maybe we can prevent some antipsychotic drugs from being administered. And maybe there's other alternative ways that the robot itself could actually calm the person down with either music or dialing a loved one and have them talk to. Because let's face it, when you're in a mental health institute or a nursing home or assisted living, there's sometimes very little human interaction. So to be able to do that, obviously the robot's not as good as the human, but maybe it's the next best thing for the time being until we improve that condition. So I think that's it.
That's a good estimate. Thank you, Dwayne. So, Jeff, let's go back to LLMs for the final question. How can LLMs reduce administrative burdens and augment what clinicians do in the area of research?
All right, research, great. So that's what I do myself. So the simple task that we've used it for is doing automated literature reviews. So if you're a researcher, the first thing you do when you start a project is you go scour the literature and find the articles that are important and put them into some document to identify what are the gaps, what do we know, what do we don't know, in order to determine how to design your particular study. Well, you can just go type in any one of these large language models and you can ask it the question. Let's say we're doing a project right now on COVID and diabetes, and you just ask it, what's the literature on COVID and diabetes? And it'll spit out 10 pages of information with literature that's been recently published and summarizing that literature and the most important research questions. You can do follow-ups and ask it to provide more information and so on. So that's one thing that it can be used for, and it's pretty effective at that. Another one is identifying patients for clinical trials. So one of the hardest things we have to do in clinical settings and in translational science is get patients into trials. And you want to find the right patient to get into that particular trial. And so some of these models can analyze our data that's in our electronic health record and give us a list of patients that are appropriate candidates for our trials. And we know when they're going to be in the clinic the next time, and we can go and ask them to recruit them to be in those trials. A couple other research pieces I'll mention that are enabled from some of this technology and some things that we've been doing here at UK is around imaging. So if you have imaging, you can think of radiology, pathology, ultrasound images, that we can use AI tools that can look at an image and tell us, is that a cancer, is that a tumor or not? And it's really good at doing that. One of the things that pathologists do that Cody and I have actually been working on is there's some automated segmentation programming that you have to have a pathologist look at images and tell you which one is a cancer, which one's not. That's called annotation. That takes a long time because they have to go through every image and do this. Well, some of these tools now, the pathologist identifies one little image and says, or one piece in the image, this is what I'm looking for. The computer does the next one and says, is this right? You say yes. It does the next one and the next one and the next one. Then it does them all, and it's done. What would have taken hours and hours, it does just within minutes. So imaging, ultrasound imaging, we've got one where the ultrasound person or technician is looking for a specific feature, let's say in a kidney, and when that feature pops up, the screen alerts and says, that's it. And instead of searching and taking video and then letting someone else look at the video later, the computer can help guide that technician as they go do those ultrasound images. Natural language processing is another one that we do. And so this is computers basically reading text and deferring information from text. So we have lots and lots of text about patients. In fact, usually hundreds of pages of text about a particular patient. Well, I can read that text, or I can hire a clinician to read that text and look for certain things that I'm interested in. or I can tell the computer to go do it, and the computer does it in about 90% accuracy compared to what a person would do. And the computer can do thousands of text documents as opposed to a person. It may take them a long time to do that. Genomic pipelines. So if we do a genomic screening on a person, a lot of clinics will actually send that out somewhere, maybe come back in a week or longer. We can actually do that now and with the latest tools that are available. Some are accelerated, and that it can be done in less than a day, sometimes even shorter than that period. So it really speeds up some of the things that really took a long time to do before. And this last one I'll mention is called synthetic data. I don't know if anyone's heard of synthetic data before. But one of the things that we worry about in healthcare is the security of our data. And in my business, I'm a data person, so I need data in order to do analysis. And so how do we make the data that I use be secure? Well, we can take these models, apply it to a data set, and generate what's called synthetic data, which is kind of like a copy of the data, but it's fictitious. And so there's no real names in there. There's no real people in there. There's just people that look just like kind of the people that were in the real data set. And I can use it all day long. I can post it on the internet. There's synthetic data sets available that you can download and do your own research on. They're based on real things, but they're not real things. And so it really protects patient privacy in the greatest degree. So those are some examples of things we're working on these days.
So Jeff, I want to follow up on that. So I think a lot of institutions are looking in this area and saying, how do we develop and how do we take legacy data into these LLMs? Is it vital that you upgrade your documentation system before you do that, or can you use existing documentation systems?
I mean, it can use existing documentation systems for sure. So depending on what your use case is, but really just kind of having that EHR text. We do it with our current EHR system, but we have an older one that we can use it for. It works equally as well. It's slightly different because it captured different fields, but the structure of the data doesn't matter as much as the content that's in the data. And so, yeah, so that really is not a limiting factor for us these days.
Super. Thank you. Well, gentlemen, now we're going into a rare area. It's called off the script, so prepare yourselves. Okay, it's Carl's time. Okay, Cody, I'm going to start with you. We've been talking, you and I have been talking about creating a chatbot for recovery, for peer support training, that a trainee would be able to sit down and have a conversation with and be able to practice what we're teaching them. Tell me your thoughts around that.
Well, if we had this conversation a year ago, it would be very, very different. I think it probably would have led from what was mentioned before, looking at kind of a sentiment analysis on facial recognition, but these large language models, which fall in the same class as ChatGPT and GPT-4, they're not what they call general AI, meaning these things aren't learning by themselves. They aren't making decisions. They're generating information, but they're doing so in an unstructured way. The question was just asked, Jeff, can you use old EMR data? Well, the problem we had previously with old EMR data was that we had to try to extract discrete things out of unstructured tests, and that was the nightmare for everybody doing kind of any kind of AI and machine learning work. Where the large language models, what they allow us to do is to kind of throw things in a bucket, and it's done in a conversation system. When you're talking about setting up training, you have a question, and then you have an answer, and maybe you have a series of those that function as a chain of thought that you can start training against. What starts becoming interesting with the large language models, because they are trained on large corpuses of text of different types, is that the generative approaches start looking like it's thinking or coming up with things. So what's considered zero shot or generative in this respect would be for the language model to start answering questions reasonably on things that it's never seen before, and also to infer based on different scenarios. So these large language models now aren't just language. They can include images, and if you can include more than one image, you can include clips of video. So there are models now that we can download, and you can train it against a video of somebody riding down the street with a horse and a dog running past, and then you have the question, maybe a text saying, this is a Western scene, and there's a person, there's a horse running across, and maybe there's a stop sign or a building, not mentioned in the text, but it's in the image. What ends up happening is that you say, the response is, what's happening in the scene? Maybe you include all those things, maybe you don't. Maybe you just say that this is a Western scene and people look happy. The images are now encoded in what looks to the machine similar to text, and they're used combined with the text to enhance and describe the scene. Multiple videos, just multiple still frames of text. Now with that text, you can see we've described in some respects from unstructured data some structure of the scene, but also in an unstructured way, meaning you're providing hints. And you do that over and over and over and over again. So if you have the Western scene and you have 10 of them and different things are being described, and then you show a new scene that has components of that, the model in many cases can infer based on those other things it was trained on what's happening. Now here's where you get into the hallucinations and the problems to say maybe it's right, maybe it's wrong. But when it comes to, say, treatment or developing a model developing a personality, that's coming from the responses that you provided, the overwhelming responses you provided. And if it is functioning as a therapist, if it's using that language, if that's the scene that's being described, this person's doing this person's doing that, you can do that with audio, you can do it with video, you can do it with text, and you can do it with still pictures. So I don't know if that described what you were
Yep.
saying, but
Exactly.
that's kind of the level of capability. The quality of that, I can't really speak to. I think it would be based on the individual task.
Good. So, Dwayne, question for you. We heard today that, and we know because I'm from Eastern Kentucky, rural healthcare is woefully underemployed. We have a need to meet these gaps, and that's what we do at CPE. We meet gaps. We look at workforce gaps and meet them. Tell me how you see your robotics affecting that.
Thank you, Carl. Well, obviously, we're never going to replace any jobs, but we can definitely augment those jobs. Again, I can mention that you've got a cleaning crew of 10. Well, maybe you only need a cleaning crew of 6, and then you augment that with the robots, and then you have robot fleet managers. But the robots were intentionally designed and built for what we call the 3Ds. Those are those dirty jobs, the dangerous jobs, or just those dull jobs like cleaning and so forth. But where we can see that, and especially in the rural areas, and obviously we're going to have probably better internet accesses to some locations, but the telehealth, the remote health, using the robots. Obviously there's nurses shortages or they're just burnout. So can you supplement some of the work that they're doing, again, the delivery type things that nurses do, just going back and forth. Well, patients, they're always asking for something that they need, but sometimes they just need a drink of water or a snack or something like that. Again, the robot can be that person or that replacement supplement to a nurse or an attendant, so they don't have to walk those extra steps. Takes that extra effort. Again, the whole effort is to allow them to spend more time with their patients, which is their number one goal, and hopefully be able to add that personalized touch. I think several of us have been in the hospitals before where the nurses and doctors come in for 30 seconds, 45 seconds, and then they leave. Well, I think the robots will allow them to spend more time with the patients and do their most important tasks.
Super, excellent. So Rick, I want to go back into the classroom at KCTCS. I want you to tell us what activities are, if you can provide us, what activities at KCTCS are currently ongoing to address AI?
Yeah, so this is a new area for us, like everyone else, and there have been multiple work groups formed at various colleges. So if you don't know KCTCS, we have 16 colleges in the state. So each one of those kind of is autonomous and has its own plan and its own, steps, action plans about how to deal with this sort of thing. So that's one of the first things, is just getting the right folks on our campuses together to talk about what to do and how to do it. Some examples I've heard going on campuses are related to syllabi in particular. So how to write an effective syllabi for our faculty to incorporate issues related to AI in terms of the expectations for the students. And that's a big thing to do at the beginning of a course, especially if you're thinking about providing writing assignments and that sort of thing, and you're worried about ChatGPT kind of writing those assignments for your students. And so clearly articulating what your expectations are for the students at the beginning is essential. And so for a lot of our faculty, it would be a new statement in their syllabi about AI, how to deal with it. And, we've always had statements in syllabi about, cheating and dishonesty and that sort of thing. But so now we're going to have a new section in our syllabi that's, how to use AI responsibly, how to use AI ethically in the classroom, how to use it to your benefit as a student so that it's not kind of curtailing your learning. And so that's a big challenge, and I think for a lot of our colleges, it's probably going to mean bringing in outside experts to give seminars and lectures to our faculty about what to do and how best practices around these things. And then also to kind of generate innovative ideas in the classroom. So how AI can be used, like I mentioned before, to generate new assignments and new ways of thinking about learning. And so I think it's a frontier for most post-secondary institutions, and I would say K-12 as well, to try to figure those things out and to do it in a good way so that the students are benefited.
Excellent. Thank you, Rick. Jeff, last question. So most professional publications have this year proclaimed 2023 as the year of AI, but that's not actually correct. AI in pathology, in radiology, has been around for 15 plus years. So kind of give us a timeline of how AI is developed and where do you see that next quantum leap?
Yeah, that's a great question. So it does really go back maybe 20 years probably to where we had the first AI models. And I guess maybe there's been even 3 or 4 kind of cycles of AI booms, like in the 60s, and those kind of died down when they didn't work out as well as we thought they would. It came back about 10 years later and so forth. It's done this several times. I think before the ChatGPTs of the world and the large language models, the best we could do were these things called deep learning. And deep learning models are a form of AI, and they basically were able to really do predictive modeling much better than kind of current statistical methodologies could do if your task was just prediction. And so a lot of the best, like the self-driving cars, were all built on these kind of deep learning models that could make these decisions, go left, go right, go straight kind of things, right? And they're really good at doing that. The LLMs kind of just turned that on its head and basically could do the best deep learning models that even we had some that we were working with that we applied a simple, right off the shelf LLM, and it beat what we had been working on for about a year before without even any training. And so so I think this quantum leap has happened now with the current models. The next generation of that leap is how they get implemented and used across the board. And so, I really like the question about how universities are using this. At UK, we've had a committee trying to decide how do we use AI appropriately on our campus. A lot of it is around with students. What do you tell students to do this? Anybody in here, if you haven't typed a question into ChatGPT, you have to do that. It's an amazing experience, and you won't believe it. And then just keep doing it. Just keep asking it more and more harder things, and you'll just be really surprised. But the one thing that we can't do very well is we can't detect when someone has used an AI tool. So if a student turns in a paper, there are tools on the market, but most of them have been shown not to be very accurate. So one of the things that we had to tell our folks at UK is we can't detect accurately someone who turns in a paper that's used AI that didn't have permission to use AI. So we have these tools. One of them is called turnitin.com. And we've had that at campus for years. It no longer works because it can't detect when someone has used an AI tool to write their paper. So, I think that the implementation of these tools and using them in everyday life as we go forward is going to be pretty amazing. But there'll be some challenges along the way as well.
Excellent, thank you. So ladies and gentlemen, as we wrap up this panel session on a crucial topic of augmenting the flow of work in healthcare with AI, I want to express my gratitude to our distinguished panelists for their valuable insights and to all of you for your engagement in this discussion. So we're going to turn it into question time now, and we've, I think, have some questions here up. Do we have any? Anyone have any questions? Are they're cycling up? This is not using AI, so.
If you can go back to the code,
We can just, you just want to do a mic? Oh, here we go. So, first question. What excites you the most about using AI to improve work design? Gentlemen? Anyone? Cody?
What's work design?
Redesign, I'm sorry. Work redesign.
I need glasses and I can't see it.
No, I've got glasses, didn't read.
I think in many cases, what's exciting is that a lot of times these things work and work well. For me, I didn't, and I mentioned this earlier, we've been trying at least since I started medicine in 2017, I was there before, to essentially shove technology at people and saying, seriously, this works, we can do it. And that's difficult. And sometimes it's hard to obtain data and hard to figure out how it fits within the system. And hospitals typically aren't motivated, in many cases don't have the motivated to take on the risk of doing new things like that. When I have providers all over our hospital system coming to us saying, you need to help me figure out how I use these tools, how I can make life easier, not because I like technology, but because I think this is going to save me some workload. I'm sick of working until 9 o'clock at night doing things that I'm pretty confident that this technology will help with. So I think generally being able to show, and this is the same for the last 30 years, being able to understand and use technology to directly impact the health of others. It could be for the providers their mental health, but certainly the quality and effectiveness of treatment for Kentuckians and people in our care is probably the most exciting thing.
Thank you. Rick, this one's for you. How is AI usage being implemented in the classroom, and how are you empowering faculty to integrate it into their lesson plans?
Yeah, that's a great question. I think at this point, my answer would be I don't know, because we actually haven't collected data on this to measure it. I think that's going to be probably in our office where I work, a task for us in the future is to start assessing AI and how it's used and how it's affecting student outcomes. But at this point, we haven't really done the data collection to know how it's being used, especially for individual faculty members. And I think probably for most of our faculty, they are themselves still trying to figure out how they're going to implement AI in the classroom and redesign lesson plans and that sort of thing. Unfortunately, I think my best answer to that question is I'm not sure at the moment how it's being implemented in the classroom, except that I think there is some evidence out there that there are professors using it for planning purposes. I've mentioned it a few times, coming up with unique lesson plans around it and figuring out, more exciting ways and more exciting assignments.
Yeah. Thank you. Jeff, this one's for you. There seems to be hesitancy with taking certification exams, especially with minority students. What are the benefits of using AI towards exam preparation? I think this is a biasing question.
Yeah, I haven't actually done making exams with AI tools yet. That interests me, though. Now that you say that, that sounds kind of like a good thing to do. But I can tell you that, like, what I've done in my class this semester is I've told students, UK kind of gave us three choices to use in incorporating AI in our classes. And the first one was outlaw it and say, no, students, you can't use it. The second one was you can use it, but only under certain circumstances. And the third was use it any way you want, as long as you tell me you did it. And so I use that for my students, and they write a paper every week in my class, and I told them, I encourage you to use it because your paper is going to be much better if you use it to do that, but just tell me how you used it. And then every time we come to class, their papers are much better. I enjoy reading them more. But then we talk about it and say, how did you use it? How did it help you? How did it not help you? And sometimes it actually doesn't help them. That they say, I tried it and it told me all these crazy things that were wrong. And so I went back and just kind of used the library and the old-fashioned way of readings and things. So to get around it that way.
Excellent. Dwayne, I want you to hit this one. This is from Dylan. I know Dylan, and welcome, Dylan. Serving a very rural community, and I think Dylan is from Hazard and Big Sandy area. Community folks are typically skeptical of advanced technology. How do we ensure patients are comfortable with robot AI interactions? And I think that's a robotics question.
I think you would agree, and that's a very tough question because we see it all the time. I'll use an example of something simple like a delivery robot that has been tested for several years on that last mile. There's the old saying, why use a 6,000-pound car to deliver a 8-ounce burrito. So that's the same philosophy as why we're trying to use smaller robots more efficiently and so forth on that last mile. But we see, when they already are interacting with the community, like in a delivery situation, or even yesterday when I was at the Cincinnati airport, we're implementing some robots there. Little kids come up to them, they push them, they hug them, they want to ride them, of course. They love interaction with them. But there's also people that will sabotage them, either because they're afraid of them, afraid they're going to take their jobs. So it's going to be an education, and I think that education begins in the K through 12, where we want to implement more robots in the schools, whether it's just running Johnny's lunch from the front room to the classroom, and then have it where, particularly in the future, where AI is really integrated with it, to interact, as it's walking through the hallway, interact with the students, and they can talk to them, ask questions. How's the weather? What's it look like? What's the Reds look like next year? So all types of questions that can interact. And I think once you get them when they're younger and they get more accustomed to the technology, just like computers, and folks of my age, went through school with a punch card system, we never envisioned what computers would be, 50, 40 years later. So the same thing is happening in the robot revolution, is that we'll see this revolution happen. It has to happen because as we see the workforce, we've got to be able to augment the workforce, or there's going to be both businesses and other service industries that are out of business at this point. So I think capturing them when they're in the grade school is important. And it all goes in with the STEM technology. So, incorporate robotics in with the STEM, give them, examples that run around the school, and they'll be more interactive with them and more accepting of the robots.
Thank you, Dwayne. Cody, I think this is one for your wheelhouse. When do you think payers will start paying for AI-generated work products versus provider-produced work products now available? And that may go back to that government approval cycle.
When it's cheaper?
Hmm?
When
Yes,
it's cheaper?
too.
I think we saw some things go through with emergency authorizations with COVID and kind of how we would conduct certain sorts of testing. It's kind of going the other way. The draft, the FDA just released the draft legislation on severely limiting laboratory developed tests, which was an area that I was pushing to say that we did have regulatory pathways for developing tests in-house for AI. There are still methods that we can use for software as a medical device for therapeutics. So the FDA, that goes through FDA approval as well. But it's 2 to 3 million at a minimum to go through the regulatory process for drugs, and it's around 20, 30,000 for the software as a medical device. So I believe one pathway certainly is FDA approval of the therapy. There's a couple ways of doing that, but it may actually get harder to be reimbursed if you're trying to do it in-house. That doesn't go through that approval.
Thank you. So Rick, question for you here. The security question. Is there a way to keep students from cheating with AI? And how do we make sure students are professionally competent?
Yeah, so I think students are always going to be, as a group, as a whole, there's going to be some dishonesty no matter what you do. That's been my experience. And so, that is what it is. And so is there a way to keep students from cheating through it? I think Jeff mentioned that there are kind of like countermeasures that are out there that are AI, detecting AI. But I think we don't really understand how accurate those detection methods are. And Jeff mentioned, what was the...
Turn it in.
Turn it in. I've used Turnitin. I didn't like it. I think there are going to be companies that are probably developing these tools to do this because there's going to be a demand for it. But I don't think we're ever going to get away from students potentially trying to use their cleverness to work the system, because they are very clever, and a lot of this technology, they're probably beyond where we are as a faculty to know what to do. So that's my best answer to that, is that I think we're going to eventually see those tools and they'll eventually be better, but right now it's questionable.
So last question, Dwayne, and this is always a proverbial question. How does the cost of robots compare to human labor, environmental service workers?
Sure. So keeping on the theme, the ES worker, that would be someone who would be, obviously cleaning hospitals, medical facilities, and so forth. So we have an ROI calculator, and obviously different labor rates, different places, and so forth. But let's say $20 an hour, maybe a typical rate for someone with benefits and so forth. You're going to see a payback in less than a year on something like that. If you think about it, a robot never calls in sick, doesn't take breaks, doesn't have to go to the bathroom, so they're working a full 8-hour shift. And let's say you've got 10,000 square feet to clean, disinfect, and so forth. Well, that robot can do that in one shift, whereas it might take maybe 2 people to do that much work. Again, it's back-breaking work, dull, not maybe so much dangerous, but nobody wants to do that kind of work. So that's what the robot does to supplement the work, allows those workers to free them up to do something more of a high-value job. And I think when you start implementing, and kind of going back to the question of how can you get people to, especially in rural areas, to accustom to technology, you got to introduce that to them and show them that it's not taking their jobs, but it's allowing them to do their jobs better and more efficiently, and maybe they can actually climb the ladder quicker by doing higher level tasks than what the robot is intended to do. So, thank you.
Thank you, Dwayne. Well, gentlemen, it's been a pleasure. Thank you for your time. Thank you for your comments, insights. I believe that ends our session. We are on...